Welcome back to the deep dive. We've got a pretty hefty chapter here from medical surgical nursing, all focus on male reproductive health problems. Our job today, cut right through to what you absolutely need to know. We're talking nursing priorities, the core pathophysiology, those critical safety alerts, basically skipping the fluff so you can get the clinical picture fast. It's all about synthesis. We're pulling out the high-yield stuff, connecting the dots between big concepts like cellular regulation and elimination. These things often show up together in patients, right? So let's unpack it. How should we frame this?
Yeah, that's a great way to think about it. The chapter really hangs on two main priority concepts. First, elimination. The classic example here is benign prostatic hyperplasia, BPH. And second, cellular regulation, which, is the core issue in prostate cancer. And as we go, you'll see how other related ideas like infection, sexuality, even reproduction, they all weave through these main problems.
Okay, good framework. And just so we're all on the same page, let's nail down a few terms from the start. When we say BPH, we're talking about hyperplasia, right?
Yeah.
Which is
Right, it's an abnormal increase in the number of cells, making the tissue larger. Not bigger cells, just more of them.
got it. And we'll hear LUTS a lot lower urinary tract symptoms. That's just the catch-all for all those bothersome urinary issues from an enlarged prostate.
Exactly. Everything from trouble starting to, well, going too often.
Which brings us to nocturia. Waking up repeatedly at night to pee, probably one of the most common complaints.
Oh, definitely. A major quality of life issue for many men.
All right, let's jump into that first concept then. BPH, benign prostatic hyperplasia. You mentioned it's common, but the numbers are kind of wild, aren't they? Affecting like 80% of men over 80?
It's incredibly prevalent. Essentially, it's a normal part of aging for most men. Pathophysiology-wise, it's driven by aging itself and hormones, specifically dihydrotestosterone or DHT. This DHT makes the glandular tissue in the prostate grow that hyperplasia we mentioned, but crucially, it grows inwards, pushing up into the bladder neck.
Creating a blockage.
Exactly. That's the bladder outlet obstruction, the BO.
Okay, so the bladder's trying to push urine past this blockage. The muscle, the detrusor, gets thicker.
It does. It hypertrophies, trying to compensate. But eventually, that muscle can get tired. It fails.
And when it fails, what does the patient actually experience? What are the consequences?
That's where the real problems start. You get urine left behind in the bladder, residual urine, or stasis. That stasis can cause chronic issues like overflow urinary incontinence, that constant dribbling.
Oh.
Yeah. Or it can lead to an acute situation, acute urinary retention, AUR, where they suddenly can't void at all. That's emergency. And if that retention becomes chronic, the urine backs up. First into the ureters, that's hydrorator.
Okay.
Then potentially all the way up to the kidneys, hydronephrosis. And that's serious. It can lead to kidney damage over time.
Wow. Okay, so a simple prostate issue really isn't simple at all. What about risk factors? We know age is huge. Race, too. You mentioned black men might need treatment sooner. And genetics.
Right. Those are the big unmodifiable ones. Age, race, and certain gene variants like Geta3. Can't change those.
But there must be things we can change.
There are. Obesity and metabolic syndrome are definitely linked to a higher risk of developing BPH. And for guys who already have symptoms, drinking a lot of coffee or caffeine seems to make the LUTS worse, speeds up the progression. So lifestyle counts.
Okay. So when we assess someone, there's a standard tool, right? The IPSS.
Yes, the International Prostate Symptom Score. It's a questionnaire that quantifies the severity of their LUTS hesitancy, weak strain, feeling like they haven't emptied, straining, dribbling, and of course that nocturia.
And then the physical exam, the DRE, digital rectal exam.
Absolutely essential. And the key finding for BPH, what the provider feels, is typically a uniform, elastic, non-tender enlargement. Smooth, kind of rubbery. That feels different from cancer.
That's a critical distinction. And after the DRE, checking residual urine.
Yes, usually with a bladder ultrasound right after they void. It tells us exactly how much urine is being left behind, quantifying that stasis problem.
All right, let's shift to management. If we're starting non-surgically, what are the go-to behavioral changes?
First things first, manage fluids. Don't drink huge amounts all at once, especially before bed. Cut back on alcohol and caffeine. They have a diuretic effect and can irritate the bladder. But probably the most important thing, from a nursing perspective, is medication awareness.
How so?
Patients absolutely must avoid drugs known to cause urinary retention. Think common over-the-counter cold meds with antihistamines, certain antidepressants, muscle relaxants, even some prescription drugs. They can tip someone with BPH into acute retention.
That's a huge safety point. Okay, if behavior changes aren't enough, then drugs. You often see two types used together.
Yeah, the combination approach is very common and often most effective. You've got alpha-1 adrenergic antagonists, drugs like tamsulosin. They relax the smooth muscle in the prostate and bladder neck, making it easier to void. And then you have the 5-alpha reductase inhibitors, or 5-ARIs, like finasteride. These actually work to shrink the prostate over time by blocking that DHT conversion.
Okay, and those 5 ARIs, I remember there's a significant safety alert there.
Big time. Nursing safety priority right here. Two key things with 5-ARIs. First, they take time up to 6 months for patients to really notice an improvement. Manage that expectation. Second, and this is critical, they are teratogenic. They can cause birth defects in a male fetus.
And how does that impact nursing care and family teaching?
These drugs can be absorbed through the skin. So any woman who is pregnant or could become pregnant should not handle these tablets, especially if they're crushed or broken. They need to be stored safely away.
Wow. Okay. Anything else with these drug classes?
Yes, the alpha blockers, the tamsulosin-type drugs. They relax smooth muscle, including blood vessels, so they can cause orthostatic hypotension dizziness when standing up. Teach patients to change positions slowly, especially when starting the drug.
Good points. So when drugs and lifestyle aren't cutting it, surgery becomes an option. The TURP, Transurethral Resection of the prostate, used to be the main one.
It was the gold standard for a long time. But now we're seeing more minimally invasive procedures, like prostate artery embolization, or PAE. They tend to have fewer complications, especially less risk of long-term incontinence or erectile dysfunction, which are major concerns for patients.
Makes sense. But if someone does have a TURP, post-op care sounds pretty intense.
It really is. Precision is key. Pre-op teaching is vital. Tell them up front. They will feel like they constantly need to pee because of the catheter balloon. They'll have some discomfort, maybe bladder spasms, and their urine will be bloody at first. Setting expectations helps reduce anxiety.
And post-op, the continuous bladder irrigation, the CBI, that 3-way catheter setup, how do we manage that accurately?
Okay, this is core nursing knowledge. You've got irrigant fluid going in and a mix of irrigant and urine coming out. To know the actual urine output, you have to do the math. You take the total volume in the drainage bag and subtract the total amount of irrigant fluid you've instilled over that same time period. What's left is the patient's true urine output. Monitoring that is crucial for fluid balance and detecting problems.
Right. And speaking of problems, what are the immediate threats we're watching for in recovery? Bleeding is a big one.
Huge. And you need to know the difference. Arterial bleeding is an emergency. The drainage looks bright red, thick, like ketchup, often with lots of clots. You notify the surgeon immediately.
Okay, ketchup-like equals bad.
Exactly. Venous bleeding is more common, usually manageable. The drainage is darker, more burgundy-colored, still needs monitoring, might need irrigation adjusted, but less acutely dangerous.
And the other major immediate risk, TURP syndrome.
Yes, it's rare, but potentially fatal. It happens if the body absorbs too much of that irrigation fluid into the bloodstream during the procedure.
What does that look like? What are the signs?
The nurse needs to be hypervigilant for headache, dizziness, confusion, maybe nausea. Also, look for vital sign changes like bradycardia and new-onset hypertension. Any combination of those, you stop the irrigation, alert the surgeon immediately. It's basically acute hyponatremia and fluid overload.
Scary stuff. Okay, wrapping up BPH. We can't ignore the psychosocial side. Things like incontinence, nocturia, they really impact quality of life, self-esteem.
Absolutely. And postoperatively, nurses need to be ready to discuss sexual function. Reassure patients that BPH surgery itself shouldn't cause ED, but retrograde ejaculation where semen goes into the bladder instead of out is a common possibility after TURP.
And incontinence.
It's often temporary after surgery. Teaching Kegel exercises before and after surgery is really important to help regain bladder control faster.
Okay, that's a really thorough look at BPH and elimination. Now let's pivot to that other major concept, cellular regulation, using prostate cancer as the example. How does this differ fundamentally from BPH?
Well, the location is a key difference, pathologically. BPH usually happens in the inner central part of the prostate. Prostate cancer, though, typically starts in the posterior lobe or the outer portion of the gland. That's why DRE can sometimes pick it up as a distinct nodule on the back surface. It's also generally a very slow-growing cancer, which is good news in one sense. But it does metastasize predictably first to nearby lymph nodes and then commonly to bone, especially the pelvis, hips, and spine.
And risk factors. Age is still number one.
Age is the biggest, yes. Also, being African-American significantly increases risk and often leads to earlier onset or more aggressive disease. And a strong family history, having a father or brother diagnosed before age 65, that's a major red flag.
So how does that affect screening advice? It seems a bit controversial or varied.
It is. The general guideline now is for men age 55 to 69 to have an informed discussion with their provider about the pros and cons of screening. It's a shared decision. But for those high-risk guys, African-American men, men with that strong family history, that discussion should start earlier, around age 45.
And often, early cancer has no symptoms, right? So screening is key. What are we looking for?
Exactly, often asymptomatic early on. If symptoms do appear, they're usually LUTS, similar to BPH, because the tumor eventually causes obstruction. On DRE, instead of that smooth, elastic feel of BPH, the provider might feel a stony hard nodule or irregularity. That's highly suspicious for cancer.
And the blood test, the PSA.
Prostate-specific antigen, PSA. It's the standard screening test, but it's not perfect. It could be elevated in BPH or infection, too. There's also a newer marker, EPCA2, which might be more specific for cancer. But here's a critical action alert for nurses regarding PSA. Always draw the blood for the PSA before performing the DRE.
Why is that timing so important?
Because the DRE itself, manipulating the prostate, can temporarily bump up the PSA level, giving a false positive or artificially high reading. You need the baseline before any manipulation.
Got it. Draw before DRE, and ultimately, diagnosis requires a biopsy.
Yes, usually a transrectal ultrasound TRUS-guided biopsy. That's the definitive way to diagnose prostate cancer.
And post-biopsy. What instructions do patients need?
They need to watch for signs of infection fever, chills. Also, report any significant bleeding in the urine, stool, or semen, or if they have trouble urinating. And definitely avoid strenuous activity for a day or two to prevent bleeding at the biopsy sites.
Okay, so once cancer is confirmed and staged, treatment decisions get complex. Let's talk options. What about active surveillance or AS, just watching it?
It sounds passive, but it's actually a very specific strategy. AS is typically for older men, or those with significant other health problems, who have low-risk, slow-growing tumors found early. The idea is to monitor the cancer closely with regular PSA tests, DREs, and maybe repeat biopsies, but delay or avoid treatment and its side effects like ED and incontinence unless the cancer shows signs of progressing. It's balancing risks.
Makes sense for certain patients. What about non-surgical treatments aimed at cure or control?
Radiation is a major one. It can be delivered via external beam radiation therapy, EBRT, which is like SOCUS X-rays from outside the body, or through brachytherapy, where tiny radioactive seeds like grains of rice are implanted directly into the prostate.
What are the downsides of radiation?
Both types can cause side effects. Short-term, things like urinary frequency or burning, maybe rectal irritation, radiation cystitis or proctitis. Long-term, the big concerns are erectile dysfunction and sometimes chronic urinary or bowel problems.
And then there's hormone therapy, ADT.
Right, androgen deprivation therapy. Since many prostate cancers need testosterone to grow, ADT aims to shut down testosterone production or block its action. We use drugs like LHRH agonists, leuprolide is a common one, or antiandrogens like flutamide.
And there are significant side effects with ADT too, right? Another alert.
Absolutely. LHRH agonists basically induce chemical castration, so men experience side effects like hot flashes, decreased libido, ED, and often gynecomastia, breast enlargement. A really important long-term risk is osteoporosis. Blocking testosterone weakens bones over time, so monitoring bone density and preventative measures might be needed.
And the antiandrogens?
They can cause liver problems, so regular liver function tests are essential.
Okay. Then there's the surgical option for cure. Radical prostatectomy, removing the whole gland. Are minimally invasive approaches common now?
Very much so. The laparoscopic radical prostatectomy, LRP, often done robotically, has become standard in many places.
What are the advantages for the patient?
Smaller incisions mean less pain, less bleeding, shorter hospital stay, quicker recovery overall. But maybe the biggest advantage is the potential for better nerve sparing.
Meaning preserving erectile function.
Exactly. The nerves controlling erections run right alongside the prostate. The enhanced visualization and precision with laparoscopy or robotics give the surgeon a better chance of carefully separating those nerves from the prostate, improving the odds of maintaining function post-op.
That's huge for quality of life. If someone has the traditional open surgery, though, what are the key post-op nursing points?
Well, it's major abdominal surgery care, but with a couple of prostate-specific rules. Absolutely no rectal procedures, no suppositories, no rectal temps, no enemas. The surgical site internally is very close to the rectum, and you risk damaging the anastomosis.
Okay, critical point. What else?
Catheter care is paramount. They'll have an indwelling catheter for quite a while, maybe 7 to 10 days, sometimes longer, while things heal. Teaching catheter care is essential. And long-term, managing the two big potential complications, ED, often with medications like sildenafil, and urinary incontinence, again emphasizing Kegel exercises.
Okay, that covers the big two, BPH and prostate cancer. Let's quickly touch on a couple of other conditions mentioned. Testicular cancer.
Right, much rarer than prostate cancer, but it's the most common cancer in younger men, typically ages 20 to 35. The really good news is it's highly curable, over 95%, especially if caught early. The main risk factor is a history of cryptorchidism, an undescended testicle.
And management?
Usually involves surgery to remove the affected testicle in orchiectomy.
So for nursing, the priority is education for this age group.
Definitely. Emphasize the importance of monthly testicular self-examination, TSE, for early detection. And because these are young men, always discuss fertility preservation sperm banking before any treatment begins.
Crucial conversation. Okay, last one. Erectile dysfunction, ED. How do we approach understanding the cause?
The key is distinguishing the pattern. Organic ED tends to have a gradual onset. It's often linked to underlying physical problems like diabetes, hypertension, vascular disease, things that affect blood flow. Psychogenic ED, on the other hand, usually starts suddenly. It's often linked to stress, anxiety, depression. The big clue here is that men with psychogenic ED typically still have normal erections during sleep or upon waking in the morning. That points away from a purely physical cause.
And when treating ED with drugs like sildenafil, the PDE5 inhibitors, there's that one absolute non-negotiable safety rule.
Cannot stress this enough. These drugs must never, ever be taken with nitrates like nitroglycerin used for angina.
Why not?
Because the combination causes profound vasodilation, leading to a potentially fatal drop in blood pressure. It's an absolute contraindication. Patients need crystal clear education on this.
Any other common side effects they should know about?
Yeah, common things are headache, facial flushing, maybe indigestion, usually manageable, but the nitrate interaction is the life-threatening one. So quite a journey there. We've covered the nursing care related to elimination problems, primarily BPH, and cellular regulation issues like prostate cancer.
Yeah.
Moving from that benign obstruction BPH to the complexities of malignancy and its treatments.
Yeah, and what really strikes me listening back is how deeply interconnected the physical stuff is with the psychosocial impact. Our role as nurses isn't just about managing the CBI or giving meds. It's also about creating a space where patients feel safe to talk about really sensitive things. Sexuality, body image, fertility, incontinence, being open, non-judgmental, supportive. That's huge.
Couldn't agree more.
So considering everything we've talked about, the high prevalence, the impact on daily life, here's a final thought for you listening. What's one modifiable risk factor we touched on? Maybe caffeine intake for BPH, or encouraging TSE, or discussing weight management that you could focus on addressing with your next patient. Or maybe what's one support resource, like the American Cancer Society's Man-to-Man program, or US2 International for prostate cancer support, that you could keep in your back pocket to offer someone. Just something practical to take away.
Excellent point. Well, thank you for joining us on this deep dive into these important male reproductive health priorities. We really hope synthesizing this chapter helps you feel more confident in your understanding and your practice.